palliative care in chronic obstructive pulmonary disease. So as I said, thank you very much for joining this session. And as we heard a lot about palliative care, it's an amazing topic and the conference sounds great. So this is my disclosure. I have no financial interest or biases to disclose. So we'll discuss today COPD landscape, the symptoms burden of chronic obstructive pulmonary disease, the benefits of palliative care in integration of chronic obstructive pulmonary disease, the barriers, the existing barriers to integrate the palliative care, and attempt to foster successful integration of palliative care. Please allow me to introduce Mrs. X, who is a 71-year-old female with a long-standing history of COPD. She was recently hospitalized for the second time in the past year due to exacerbation. She was brought to emergency department 2 weeks ago with severe shortness of breath following 1 week of increased shortness of breath, productive cough with difficulties expectorating the phlegm, increased congestion, and repeated falls, which were limiting her functional status. At this point, her palliative care performance score was 50%. A week later, she presented again to emergency room with another episode of exacerbation of chronic obstructive pulmonary disease as a result of her advanced illness. She had a progressive weight loss by that time. Her past medical history is remarkable for hypertension, dyslipidemia, diabetes, heart attack, dementia, depression, hip fracture, treated with open reduction, internal fixation, deep vein thrombosis. Her medications were short-acting beta agonists, long-acting muscarinic, inhaled corticosteroids, beta blockers, ACE inhibitors, statins, metformin, insulin, antidepressants, cognitive enhancer, and gabapentinoids. Isn't she a regular patient that we see on our unit? Let's continue to follow up with her. She was treated with intravenous antibiotics and stabilized, but became bedbound and severely deconditioned throughout her admission. Her palliative care performance score dropped to 30% and albumin level to 23. The goals of care were reviewed and she accepted comfort care. Would you be surprised if this patient died within a year? Majority of you probably will answer no, but let's see what happened. 5 days following admission, Mrs. X became acutely hypotensive, hypothermic, delirious, and developed acute renal failure with oliguria. Her palliative care performance score dropped to 10%. She was started on systemic antibiotics for suspected sepsis, but further workup revealed multi-organ failure. Her goals of care were revisited with her husband at bedside, who was her proxy, and the patient's status was changed to full code. She was transferred to intensive care unit, where she was started on vasopressors. Unfortunately, the following morning, she became comatose and passed away next day in intensive care unit. Would her experience could be different with the comfort care? Let's explore that. So as we all know, chronic obstructive pulmonary disease is a sizable source of mortality and disability worldwide. It's incurable, and the global prevalence expected to reach 30% by the year 2030. It estimated about 6 million people to suffer from this illness by the end of 2020. The numbers are shocking, aren't they? That's why we're here today talking about that. The symptoms burden of a patient with chronic obstructive pulmonary disease are almost the same like with malignancy, but even more prominent as you see on the presented graph. They're suffering from debilitating dyspnea, they have a cough which is depriving their sleep, the pain usually unrecognized, upper airway secretion is usually distressing, social and functional consequences of the disease not to be underestimated, depression and anxiety, and all the above reducing their quality of life. So a new paradigm of palliative care suggests that palliative care can go along with disease-modifying therapy. As long as patient can be managed on disease-modifying therapy, palliative care can be placed on hold and step in to help with symptoms management when there is no response to disease-modifying therapy or there is only partial response observed. Prognostication is difficult, as we all know, and disease trajectory is unpredictable with its up and down. And if you look at the trajectory of the patients with cancer, which is slow decline and rapid drop at the end, patients with COPD have their ups and downs, and we're losing them usually from acute respiratory failure. Interestingly enough, that integrating palliative care at earlier stages in patient with COPD has a great benefit. It's reducing hospital admission rate, improving quality of life patients and their caregiver, alleviating the stress of the caregiver, better symptoms control. There is a survival benefit, although there is a controversial, and the literature describes 3 months, but it is there. And the hospital cost, we can save $7,000 to $8,000 per patient with timely integration of palliative care. But unfortunately, the barriers are existing. And what are they? So first of all, the public synonymous palliative care with death due to lack of education, due to inability to understand and being aware what palliative care is and is not, what it can do and cannot. Interestingly enough, that interview of respirologists revealed that they will refer to palliative care only when they have nothing to offer. This tells us that we need the education, not only our primary care providers, but also specialists about what palliative care is and is not, what it can do and cannot. Advanced care planning are not discussed timely. We all know that the best thing to discuss goals of care, right, in patient stable condition, in outpatient office, right? But unfortunately, it's not happening. We most often discussing goals of care in acute care setting during the exacerbation when patient and their caregiver are stressed enough to go through this topic. And that's why we're getting irrational decision like in Mrs. X. Unfortunately, disease trajectory is not discussed in earlier stages of the illness, which leads us to later palliative care referral and later integration of palliative care. Interestingly enough, that the evidence saying that by discussing disease trajectory and what to expect down the road at the time of the diagnosis, improves satisfaction with the care and made patient and their caregiver to accept palliative care much more willingly at later stages of the illness. But unfortunately, we're not there yet. And prognostication is difficult, as we all know. So we're using widely surprise question, as we all know, and we try to use that with Mrs. X, right? But unfortunately, sensitivity of surprise question is poor. We're still using that to guide us when to integrate palliative care. So if acute care or even primary care provider was used surprise question with our patient timely, right? She may be managed on palliative care unit and die comfortably with the support of palliative care team and loved one at bedside rather than go through futile intervention of intensive care unit. And of course, an effective communication between healthcare setting. Additionally, geriatric population, right, and patient with non-malignant end-stage chronic illnesses less deserve palliative care for some reason, because again, lack of education, what to expect. And this population usually very rarely and much less admitted to palliative care unit and getting palliative care services compared to patients with cancer. So let's try to foster successful integration. How we can do that? As we all mentioned, that we need to educate our primary care providers, our specialists and public, our trainers, residents and fellow about what palliative care is and is not, what it can do and cannot do, and dispel the myths about synonymous palliative care to death. It was a lot of discussion in the media about renaming palliative care, palliative care to supportive care, end of life care, but do you really think changing the name will change the picture? Unfortunately not. Education is a key here. Removing dichotomy between palliative and curative care, like we said, incorporating palliative care in variety of settings, including hospital, long-term care, outpatient setting, and creating the disease-specific guidelines on education of timely integration of palliative care. Questions?
Thank you.
For those of you who are interested, we published our review in Journal of Critical Care, And we recently published our book on integration of palliative care in chronic obstructive pulmonary disease. Feel free to share those resources with the learners and your colleagues. Okay, thank you.
Thank you, Professor Helen. Yeah, if anyone have any questions or comments, go ahead and ask Professor Helen.
Well, I wish that more people would follow your lead there. You know, I don't know how to. I almost feel like you've got this great audience it's like you're preaching to the choir, because I think we all probably feel this way, and I wish your excellent points could be making it out to all of the, you know, clinical providers in the community.
Absolutely, that's a good point. We're getting there very slowly, but hopefully we'll get there one day.
So one thing I would suggest is, again, research is the most important thing. The thing that moved the cancer palliative care the furthest, and I mean, I've been doing palliative care since the 80s. I mean, it's before it was a field in the States. The thing that moved it the quickest was when the Temel article came out about instituting early palliative care in lung cancer patients and how that improved survival. As soon as doctors saw improving survival, they're like, oh, I need that for my patients. You know, so again, you know, it's a research conference, and I would urge, I mean, research in things like COPD is needed.
Yeah, it's backing us again back to goals of care, right? You may find that you may need that for your patients. You may find that they don't want resuscitation, but they would like to have their life prolonged. And the other will tell, no, I don't need it, right? I want to be comfortable.
Right.
And not to be prolonged at that stage. Yeah, absolutely.